Okay, so thank you for those of you who are here live for spending your Tuesday night here. And thank you for those of you who are listening to the recording. My name is Erica Berger. I'm an integrative psychiatrist, and I'm talking for about an hour today about low-dose naltrexone and how we can utilize it in psychiatry. Um, so just of overview, I think there's about 50 psychiatrists who have signed up, which I'm super excited about, from all over the country. And I think this is low-dose naltrexone. I'm just glad that you're here and you're wanting to learn more about it. If you do have questions, the hope is that we'll have time at the end, for those of you who are live, to answer them. You can either put them in the chat or you can just ask me at the end. And if you're watching the recording, you can email me. I had my email on the first slide here. And I really just wanted to share this info because I learned about low-dose naltrexone several years ago, and I attended a in-person talk about it by compounding pharmacy in my state. And I was super skeptical about it. And then I started offer recommending it and prescribing it for a couple people. And I've just been really surprised, honestly, of how helpful it has been for a lot of people. So it's just been a really helpful tool. So you might be someone who's well versed in low-dose naltrexone. Maybe you've been utilizing it for a while now. And this might be your first time learning more about low-dose naltrexone. And with this presentation, the hope is that you're going to be learning new things, even if you have a lot of experience, or if you're brand new to it. So you're all welcome here, wherever you are with your learning with low-dose naltrexone. And we will get started. So I don't have any disclosures. Can you, just to make sure you can see the disclosure screen here of the slide?
Yep.
Okay, great. Um, okay. All right. So just in terms of what I'll be sharing today, we'll do a little bit of an introduction. I'll talk more kind of big picture about the role of inflammation and mental health. We'll talk about the mechanisms of action of low-dose naltrexone, indications for it, so psychiatric and broader. Um, and then we'll kind of dive into a little bit more of indications for psych conditions. I'll talk about drug interactions and other considerations that are related, side effects and what to do, compounding pharmacies and kind of the ins and outs. If you are part of like a big healthcare system, you might not have a lot of or a ton of experience with working with compounding pharmacies. So we'll talk about that. And then there were a lot of questions that people had specifically about dosing. So I'll be talking a little bit about that. And then, like I mentioned, there'll be time for questions at the end. So let's dive in. So if you are a psychiatrist or healthcare professional, you probably are familiar with naltrexone being used at higher doses, particularly for, we use a lot more for like alcohol use disorder. It's FDA approved for that. But what's interesting is in the 80s, Dr. Bernard Behari discovered that at much lower doses, so typically 4.5 milligrams or less, naltrexone appeared to have these immune modulating properties that were completely different from its effects at the standard doses. So anywhere typically from 25 to 100 milligrams. So this work that Dr. Behari did, it really opened up entirely new therapeutic possibilities for naltrexone. And what's particularly exciting, I think, for our field in psychiatry is the emerging evidence supporting low-dose naltrexone's role in psychiatric conditions. And that's why you are all here tonight. There was a notable study I just wanted to bring up in 2017. I know it has a really small N of 12, but these researchers, they investigated low-dose naltrexone in adults with recurrent major depressive disorder who were already on antidepressants. And so the study showed some pretty remarkable results. So there was a 50% remission in the low-dose naltrexone group and 0% in placebo. Again, it's a really small N, but they did also find significant improvement in the MADRS scores, indicating that there must be some antidepressant effect of low-dose naltrexone. Importantly, there were no significant side effects reported. Um, and the dose that they used was 1 milligram twice a day. And so these findings align with our growing understanding of the role that inflammation plays in mental health. So a lot of the psych conditions that we treat regularly, so depression, anxiety, PTSD, likely have some inflammatory components. There might be inflammatory subtypes of these conditions, and including like OCD and broader psych conditions too. And we have a lot of patients that have comorbid conditions that involve inflammation. And so I bring up this example just to show this theoretical framework for why low-dose naltrexone might be effective in certain psychiatric presentations. And then just part of the introduction, I know I shared this on the first slide, but in my own clinical practice in outpatient psychiatry, I've really just had the opportunity to see firsthand how low-dose naltrexone can complement our traditional psych treatments that we offer people, particularly in those folks. And in my private practice, I worked with a lot of people with comorbid inflammatory conditions. So our patients with complex presentations that involve both psychiatric symptoms and inflammatory conditions. So it's just been, I've seen the benefits for people. And then for those of you who are in integrative and functional medicine, and those of you who aren't, it's just been used in those circles probably for quite some time, low-dose naltrexone, because of the anti-inflammatory and immune modulating effects. I know I've been seeing firsthand of patients who see a rheumatologist or pain doctor. I think there's more openness to considering low-dose naltrexone in conventional medicine. So I'm glad to see that. And then just to touch a little bit more on the role of inflammation in mental health, I think it's so important that we're again, using this framework. So Andrew Miller and Charles Raison. I don't know if Andrew Miller is a psychiatrist, but Charles Raison, I feel like I'm like a super fan of Charles Raison. He's a psychiatrist and he does a lot of work, really interesting research around psychedelics, saunas, and maybe not saunas, but like hyperthermia. I can't think of the word. But he's done a lot of research around inflammation as well. And so their 2016 work really revolutionized, I think, our understanding of depression by illuminating the role of inflammation. And what they found is that I think this is really important, is that neuroinflammation affects 30% of patients with major depressive disorder. And it seems that those that are often our more challenging cases, and the research actually supports this too, the ones with chronic and treatment-resistant trajectories have an inflammatory component. And in our clinical practices, like I mentioned, we see this inflammatory connection clearly. So we have our patients, who have rheumatoid arthritis, and they might develop depressive symptoms before their next biologic dose is due. Those with inflammatory bowel disease, whose mood symptoms flare when their gut symptoms act up. And then, I think about like Ozempic, but in general, our patients with obesity whose depression improves with weight loss. So it's not that these are coincidences, but this is reflecting that underlying inflammatory process that's going on where these cytokines, like IL-6 and TNF alpha, they're directly impacting brain function. And those markers, the cytokines, they disrupt the HPA axis that alters our brain circuits, which are involved in motivation and emotional processing, and even the function of the amygdala. So those can all contribute to these psychiatric symptoms, and just helps explain why people with more of an inflammatory depression, the research shows that they tend to have symptoms of not just low mood, but fatigue. And I think of like atypical depression symptoms. So fatigue, maybe eating more, sleep disturbances, and anxiety seem to be more common in those with more of an inflammatory type of depression. Let me just see what my slide says here. So studies suggest that those with elevated inflammatory markers may respond poorly to our traditional antidepressants, but may benefit from more of an anti-inflammatory strategy approach. Low-dose naltrexone, I think of omega-3 fatty acids. Something I'm curious about and just something to keep in mind, there is a high sensitivity CRP or CRP, nonspecific inflammatory marker. There's actually current trials. I don't know where they're at with it that are actually looking at if it could be used as a potential predictor for inflammatory treatment response to low-dose naltrexone. So we don't know yet, but just something that we might see coming out in the future. I'm just going to mute a few of you here, so don't mind me. There we go. Okay, so getting into the nitty-gritty of the mechanisms of low-dose naltrexone, particularly in psychiatry. And this is what makes it such an intriguing option for psych symptoms. So at our higher doses of naltrexone, so think 50 milligrams, naltrexone blocks opioid receptors completely, and that's helpful for treating opioid addiction in particular. But at lower doses, so like I said, anywhere from typically 0.5, but I would say up to 10 milligrams, it works a bit differently. So there's actually a temporary opioid receptor blockade. So low-dose naltrexone in low doses, or naltrexone in low doses briefly for a few hours, blocks the opioid receptors. And then this blockage actually triggers a compensatory response where in the body more endorphins are produced, and then it upregulates the number of opioid receptors as well. And with that increase in endorphins, people can have a relief in pain. There can be a role in mood regulation and immune modulation. The second component, which is really important, is the anti-inflammatory properties. So low-dose naltrexone modulates the immune response by reducing the pro-inflammatory cytokines. So we think of TNF alpha, IL-6, and then it also inhibits the NF kappa B pathway, and that is a key regulator of immune response and inflammation. And the third way that it seems to work is by regulating microglial activity in the central nervous system. So microglia, as you know, are the brain's primary immune cells, and they act as first responders if there are any threats. And when they are when the microglia are dysregulated, and that can often present as chronic activation, it seems to have some implication in a lot of psych conditions, including depression, anxiety, PTSD, through excessive neuroinflammation. So low-dose naltrexone appears to modulate the microglial activity through these TLR4 receptors, and that helps reduce neuroinflammation. So we're going to take a step back, and when we think about the use of low-dose naltrexone, I put non-psychiatric conditions because I think everything's connected, and we can't necessarily put in silos, but we're going to just say non-psychiatric conditions. So the common thread across all the conditions that you're going to see on the next page is basically dysregulated inflammation. And so it's the same mechanism that we're increasingly seeing implicated in many psychiatric conditions as well. So what you want to think of are autoimmune and inflammatory conditions. So there is a whole list here, and I'm not going to go over all of them. The ones in bold, I'm going to be actually focusing on in later slides. Let me just see if there's any I'm wanting to talk about. Basically, low-dose naltrexone for a lot of these conditions can help reduce pain, improve quality of life, improve symptoms, especially like IBS, reduce inflammation. So you think of like Crohn's disease and how that would be beneficial. Blood sugar regulation is really interesting because even from like a metabolic psychiatry perspective, so if low-dose naltrexone can help with regulating blood sugar, the thought is in my mind is that that has a downstream effect on improving mental health symptoms in that way. So I know that's not like a proposed mechanism, but and that's why it can be helpful for PCOS. Infertility. So low-dose naltrexone has been shown to be potentially helpful for infertility, thought to address any like underlying inflammatory issues that contribute. Autism, I'm not going to talk about it in another slide because I haven't used it and there isn't a lot of research out there. But what I found is that it can be helpful for managing hyperactivity, irritability, and self-injurious behaviors in certain subgroups of children with autism. We don't know exactly the subgroups. Um, and I know someone here had a question about PANS and PANDAS. I'm not going to go into a ton of detail, but for those who aren't familiar, it's an autoimmune encephalitis with sudden onset. Typically, we think of like OCD, tics, sensory issues, thought to be due to strep infection, but probably caused by other infections as well. I think like low-dose naltrexone, it can be part of the anti-inflammatory treatment approach. Might be a game changer for some people, starting at 0.5 milligrams daily. I couldn't find any research specifically about low-dose naltrexone in PANS and PANDAS. But theoretically, it makes sense that it would be helpful. There's just so much that we don't know yet about PANS and PANDAS, unfortunately. Okay, so this is a study I just wanted to bring up that examined whether starting low-dose naltrexone is associated with reduced use of psychotropic medications and anti-epileptics. In the anti-epileptics, I think were gabapentin, Lyrica, lamotrigine in particular. So it was a study that looked at prescription data in Norway with, I think, let's see, around 11,000 subjects. And it's interesting. So they kind of grouped people off into like how often they got picked up refills of low-dose naltrexone. And so the ones that were in the LDN times 4 plus group, they were the persistent low-dose naltrexone users. So they definitely used it regularly. And those folks, people in that group, it was associated with reduced consumption of antipsychotics, anti-epileptics, and antidepressants. And then it also showed reduced dosages of antipsychotics as well. And interestingly, there was no significant effect on benzodiazepines, stimulants, or sleep medications. And so this is just something, could low-dose naltrexone be helpful in reducing polypharmacy in our psychiatric patients? It's kind of the implication with that study. Someone had asked about low-dose naltrexone and dissociation. So dissociation, it's an experience that people can have where they feel disconnected from their thoughts or their feelings or their sense of themselves. and it can be associated with PTSD, borderline personality disorder, dissociative identity disorder, underlying trauma. And so it's interesting, with low dose naltrexone and how it might be helpful for dissociation. It's thought that because low dose naltrexone blocks the opioid receptors, leads to the increased endorphins, there's actually an increase in oxytocin as well. And oxytocin, it's associated with attachment and connection, and plays a key role in emotional regulation. So through this, it potentially counteracts the dissociative symptoms by increasing people's interoception and grounding. And there's actually been some studies, there's been three that have looked at naltrexone for dissociation, for like respectively dissociation, borderline personality disorder, and I believe depersonalization disorder. Um, and in those studies, they found, or the one with PTSD found it was particularly helpful with dissociative symptoms, and not other symptoms of PTSD. I believe, and I'll have to double check this, I believe those studies all looked at higher doses of naltrexone, not the low dose, so anywhere from 25, I believe, to 100 milligrams. So there is one study that I have on the slide here, a German study done or published in 2015, a small open label study, and looked at use of low dose naltrexone and seen if it was helpful in those with dissociation related symptoms. I don't have it on here, but the average doses that were used was between 2 to 6 milligrams a day. And, this is a small study, so take it with a grain of salt. But the findings from it were that 73%, or 11 out of 15, reported immediate improvement in dissociation and emotional regulation. 47%, or 7 out of 15, experienced long-term benefit beyond the initial treatment period. And then some people reported increased emotional awareness, increased ability to connect with others. So if you're thinking about utilizing low-dose naltrexone for dissociation in particular, I think it's important just to touch on a few considerations with it. So when we think of dissociation in our patients, it often is helpful for them. It serves as a form of self-protection. And so when we offer they go through any treatment and that self-protection is decreased or removed, that can be really challenging for people. So these are just keeping that in mind, and even like educating your patients about that too, that this is what they might expect with it. And so something to keep in mind is making sure that they have safe relationships. So patients may experience heightened emotions and increased sensitivity to their environment. So are they living with a safe person or have safe supportive people in their lives? Preparing them therapeutically is really important. So like I mentioned, they should be aware of this improved emotional awareness. It can also be challenging before it becomes beneficial. So I often use the metaphor of like, if you bang your knee on a table, it turns black and blue and it hurts and it's swollen and then it starts itching. But that's all part of the healing process. And so that it will get better. And making sure people have either a therapist or yourself that they can meet with as well. And so if they don't have this like expectation setting and education about it, they might think low dose naltrexone's effects are actually really distressing, and might not be helpful. And then interestingly enough, it can be potentially helpful for trauma processing. So it's thought that it might enhance the effectiveness of trauma therapies, EMDR, somatic therapy, and then DBT. And then when we look at specific psych conditions and the research with low dose naltrexone, depression, I would say we probably have the the best evidence. We talked about the 2017 study. There aren't a lot of studies. I don't think there are any randomized control trials, but clinically, this is where we're seeing a lot of benefit. Consider BID or TID dosing. And when you would think about using low-dose naltrexone for depression, I would say consider particularly if a patient has an inflammatory presentation. And sometimes we can't always discern this, but let's say they have increased fatigue, increased appetite, there's psychomotor slowing, increased sleep. If someone is obese, that might be an indicator that they might have benefit with low-dose naltrexone. OCD, I think I've had a handful of folks where we've trialed it, and I haven't seen people notice any benefit, and we don't have any research out there showing it's effective for OCD. Psychosis. So no evidence. Well, there was actually a study in 1998 with 21 participants with schizophrenia. They were stable on an antipsychotic and given naltrexone. Think it was 2 milligrams or 200 milligrams, I'm sorry. So a high dose of naltrexone for 3 weeks, and no clinical benefits were noted. Again, high dose is so different from low dose. So, it's hard to say from that study. But like in that study, the Norwegian one I mentioned, there seems to be a decreased dose needed of antipsychotics with low dose naltrexone. Borderline personality disorder, so it may help with mood regulation, dissociation, self-injurious behaviors. TBI. So consider low-dose naltrexone if you have a patient with brain fog, cognitive issues, fatigue related to sequela from a TBI. I have several patients who low-dose naltrexone has really been a lifesaver for them for being able to function in their day-to-day life. If someone has had a recent TBI, consider a higher dose, so more than 50 milligrams or more for several months, and then can switch to a lower dose. Autism, we talked about. ADHD, I couldn't find any evidence out there. I'd be curious too if anyone has any anecdotal stories of low-dose naltrexone being helpful for that, or OCD. Anxiety, there actually aren't a lot of studies out there, but clinically I have seen it being especially helpful for anxiety and if they have other chronic illnesses going on. Low-dose naltrexone Research Trust, which is a resource out there online. So they recommend actually starting at a lower dose than typically I start, so 0.5 milligrams and then increase up to 6 milligrams daily. And you could consider the BID dosing for that too. And then we're going to talk a little bit more about some more recent studies with low-dose naltrexone. So long COVID, basically, if you're not familiar, we don't have many, I don't think we have any evidence-based treatments for long COVID, and we don't have any biomarkers that are specific for long COVID too. So it's a clinical diagnosis, but a lot of people, common symptoms are like fatigue, brain fog, post-exertional fatigue, and just feeling not well. They can have sleep issues, persistent inflammation, and it's thought there is a level of immune dysregulation going on. And then, so the thought is that low-dose naltrexone has these anti-inflammatory properties that make it a potential treatment option. So this was a study published in 2024, and they assessed low-dose naltrexone at a full dose of 4.5 milligrams daily with NAD plus, which is needed to make ATP. They use some patches. You can look at the study to read more about it. Specifically for long COVID-related fatigue. I'll add too that they actually started at an initial dose of 1.125 milligrams, and then 1.125 milligrams daily, and then increased it up to the full dose by day 9. And so with that, this SF-36, which is like a general quality of life measurement, and the Chalder fatigue scores improved over 12 weeks. And then 52% of patients were clinical responders within 12 weeks. It was found to be safe and well tolerated. Since I'm a visual person, I hope you might not be able to read this. I can barely read this, but if you can, and I'll do my best to explain it. So this is a radar plot from that study. And so this like purple polygon here, this is showing, if you look at the words on the outside. So these were different measurements that they were looking at. So you can see like role limitations due to emotional problems, role limitations due to physical health, pain, social functioning, emotional well-being, and then energy and fatigue. And so the purple shape here is the scores before the intervention, before the low-dose naltrexone. And then the red is the scores after the 12 weeks of treatment. So you can see just by looking at this significant improvement in like fatigue symptoms, but all of these here showed improvement. And then there was another study in 2024 published from Bonilla et al. And they had an N of 108. It's a retrospective cohort study and looked at low-dose naltrexone doses of 0.5 to 6 milligrams for long COVID-related fatigue and pain. I believe the people in the study were predominantly white and predominantly women, and they were at a post-COVID-19 clinic. And the median dose used was 2 milligrams. And so they were comparing it to physical therapy and amitriptyline. And low-dose naltrexone was found to be the most effective at improving both fatigue and pain. The amitriptyline improved fatigue, but not pain. PT alone was the least effective. And I want to highlight that the median duration of treatment with low-dose naltrexone in the study was 143 days. And so that's like just under five months. And I'll be talking about this later on in the presentation, but that just goes to show that people often need to be on this medication for quite some time before they might notice any improvements in it. So low-dose naltrexone in this study showed significant improvement in both fatigue and pain. And I think I'm just looking at my notes here. So there isn't any double-blinded randomized control study done yet. I think I was on clinicaltrials.gov, and I believe they're currently recruiting for that clinical trial, which is exciting. All right, so low-dose naltrexone and MCAS or mast cell activation syndrome. You might not be familiar with MCAS, you might be super familiar, but it's basically a condition where mast cells, they inappropriately release things like histamine and tryptase that can cause these symptoms of flushing, itching, headaches, GI symptoms, brain fog, anxiety, I would say mood dysregulation too. So there is a connection with psychiatry here. And there's a lot of overlap with MCAS and chronic fatigue syndrome, POTS, fibromyalgia, Ehlers-Danlos syndrome. And so it's thought that, just see here. So low-dose naltrexone does seem to be helpful for some people with MCAS. And you might ask how that might be. And it's thought that it modulates T cell dysfunction, which is an issue with MCAS, and that reduces excessive mast cell activation and decreases inflammatory cytokines that would trigger the release of histamine that causes the symptoms. I would say that in treating patients with MCAS, they tend to be pretty sensitive. So in these patients, I would err on the side of starting really low to avoid a worsening of their symptoms, and then use a really slow titration. And they might not, I have on here 3 to 4.5 milligrams, but honestly, they might just find enough benefit at like 1 milligram daily. So just keep that in mind. And this is just a diagram I like to use to show the overlap of Ehlers-Danlos syndrome, POTS, and MCAS. They're very connected for a lot of people. And, if people have these symptoms, that's when, even if they don't have these diagnoses, that's when you might want to consider using a lower dose to start out with. Herxheimer reactions and low-dose naltrexone. So if you're not familiar with Herxheimer reactions, they are basically a temporary worsening of symptoms that someone has due to their immune system's reaction to toxins being released by dying pathogens. We see it for those of us in functional and integrative medicine. We see it when we're treating people with Lyme disease, mold illness, SIFO, which is small intestinal fungal overgrowth, or SIBO, which is small intestinal bacterial overgrowth, and then in post-infectious syndromes. And so it's when patients are undergoing antibacterial, antifungal, or detox treatments. And it's thought that low-dose naltrexone can be helpful for Herxheimer reactions because it modulates the immune response, reduces inflammation, and it's thought that the Herxheimer reactions are an immune overactivation. And this is from Richard Horowitz, who is a pretty well-known expert on Lyme disease, but he recommends in one of his books to start at 2 milligrams at bedtime, increase to 3 milligrams after 1 month, and then up to 4.5 milligrams is tolerated. Low-dose naltrexone in autoimmune thyroid disorders. So people with Hashimoto's tend to be sensitive overall to low-dose naltrexone and other medications as well. They do find a lot of people do find benefit for their symptoms, their quality of life, as well as their thyroid labs. So it's kind of this threefold benefit here. And then there can be an improvement in the antibodies seen as well. So for dosing, this is where you would err on the side of starting at a lower dose of 0.5 milligrams daily and increase dose no sooner than every 2 weeks. And if we are basically with low-dose naltrexone, if we're decreasing the attack on the thyroid gland and they're taking Synthroid or levothyroxine, we can see people become hyperthyroid. And so it's important that we monitor our patients with hypothyroidism really carefully. So watching for any hyperthyroid symptoms, so poor sleep, anxiety, checking labs, maybe more recent or more, what am I thinking of? Checking those just to make sure. And then they may need to have their levothyroxine dose decreased. So working with their primary care provider, whoever's prescribing the levothyroxine. All right. So drug interactions and considerations. So big important thing to know. Low-dose naltrexone is an opioid blocker. So any opioid agonist, so we think of opioid pain medications, Suboxone, methadone, if they're taking that and then low-dose naltrexone, the low-dose naltrexone can precipitate withdrawal and then reduce the efficacy of the opioids or the opioid agonist. And they can be used with antidepressants. It's important to know that. There was that study from 2019 that showed potential reduced consumption. So you might find that patients would be able to be on lower doses of the antipsychotics or antidepressants. And then, as I mentioned before, there's the potential for reduced dose of the hypothyroidism medication. Immunosuppressants and corticosteroids, so they may need reduced doses of these medications if they have irritable bowel disease or inflammatory bowel disease and or RA. Blood sugar regulation, so they might, if they're diabetic, they might need changes in their insulin. If someone has, really important, if someone has an upcoming surgery or colonoscopy, colonoscopy is often missed as part of procedures, but this is part of like my spiel when I talk with patients about low-dose naltrexone and in my like dot phrase that I share with people. So they need, if people have an upcoming surgery, they need to ask their surgical team what they should do, when they should stop it. In general, they should stop taking low-dose naltrexone at least 72 hours before surgery, but it's important that we defer to their surgery team. And then if they do need, after surgery, if they do need recurrent opioid pain medications, they will need to continue to stop the low-dose naltrexone. So in terms of side effects, and I include informed consent here, it's important that we educate people. So in psychiatry, off-label use is not new to us, but educate people about it. And then a big thing to keep in mind, and I remind people of this, is because sleep issues, vivid dreams are the most common side effect. We find that long-term sleep actually improves with the use of low-dose naltrexone. So if they do have sleep issues and it's tolerable, we can try switching to the daytime or morning. Tell them to stick with it if you can, if it's, like I said, tolerable enough. Other side effects people can have include headache, um, upset stomach, fatigue, worsening of their existing symptoms, and then rarely worsening mood or anxiety or anger, and that was in 1%. And if these symptom or side effects are persistent, um, like I mentioned with insomnia or vivid dreams, they can switch it to morning dosing. And then with overall, I would say reduce the dose and just titrate much more slowly can be really helpful. So compounding pharmacies, low-dose naltrexone, it is unfortunately not available as a standard prescription, so it must be specifically formulated. And so that's where we utilize these compounding pharmacies. I live in the middle of rural Wisconsin, and there are some within an hour drive. So you might not be aware of what's around you, but you can just go on Google Maps and find one. Um, they provide customized dosages and they can also offer different filler options. So that's helpful to keep in mind if you have a sensitive patient. And then they can offer capsules, tablets, or liquid formulation of low-dose naltrexone, just based on, whether that be patient preference or tolerance. And they can be either the prescriptions can be sent to the patient through mail, or they can usually be picked up in person. So some questions that you might want to ask a pharmacy about low-dose naltrexone. What filler options are available. So Avicil, one of the pharmacies I use in Wisconsin, they primarily use microcrystalline cellulose, which is also known as Avicil, and it's derived from tree pulp, and they tell me it's been highly tested for allergenicity, so it tends to be pretty well tolerated. But it's good to know like what options are out there for people. Do they offer patient education? So when they call the patient for the prescription, do they go over kind of what to expect? It's great if they do offer some patient education. Asking them what their quality control measures are. It's probably a good idea. Do they provide liquid formulations either for ultra low dosing or for cost effectiveness? I'm licensed in 3 states, so I know not all of you are in Wisconsin, Minnesota, or Iowa, but for like my own bandwidth, I've just kept with one compounding pharmacy in each of the states that I'm licensed in, and just building good relationships with them. They've been super helpful. I promise they're not sponsoring this in any way. The Bud Hoy Apothecary I work closely with, and it's just been nice to have that partnership, and you can call or email them if any questions come up. Cost, so that's something that's important to consider. I like to prepare people and tell them kind of what to expect. So again, you might want to ask the compounding pharmacies that you're going to work with, what would a patient expect to pay during the titration process and then for the maintenance. So the initial titration, it's such an I'm going to repeat this over and over, but it's such an individualized process. And so the cost can depend on how long it takes for them to get to their like good dose, their target dose, whatever that may be. And so I tell people like for the pharmacies I use anywhere from $40 to $60 for the first month. And then once they're on the dose that works for them, they can just take one capsule of that daily. And that comes out to typically around $60 for 90 days, $20 a month. Insurance does not cover low-dose naltrexone. I don't know if HSAs cover low-dose naltrexone. If anyone has any intel on that, I would be curious. If people are looking for a cost-effective option, the liquid can be a good idea. I don't remember, I want to say it's maybe around $20 a month. And then it can also be really helpful, and I'll talk about this later, for the ultra low dosing flexibility. So if you're using like a normal typical dose of low dose naltrexone, you can ask the pharmacy for a concentration of 10 milligrams per milliliter. And so if they're taking 5 milligrams a day, they would just take 0.5 milliliters of liquid daily. And it doesn't have to be like mixed with anything. They can just take it straight. It doesn't have to be sublingual either. So some practical tips. These are honestly things I've just learned along the way. With ordering refills, so the last thing you want to have to do is like call the compounding pharmacy to order a refill. I know that's at least been the case for me. So I would recommend seeing if you can order it through your electronic medical record through the e-prescribe option. So most compounding pharmacies, and you can ask them this too, they are familiar when orders come in for the 50 milligram naltrexone, but under the SIG, you're going to specify the dose, such as like 4.5 milligram dose. And you can put like 4.5 milligram capsule, I think, on there too. You can also fax the refills or call them in. But the e-prescribe option I have found to be just a lot easier. Can people open capsules to get lower doses? I tell people not to do that. It's not a precise way of getting the dosage. And then here I just mentioned build a relationship with compounding pharmacies. Just become familiar with them, and they can become familiar with you, and it's just a nice partnership. And you can also look to, if you live in like a more urban area, find ones that like on their website that they say they specialize in low dose naltrexone. I find that to be really helpful. Okay, so I'm just looking at the time. All right, dosing strategies. In bold, dosing is variable. So I tell people, and even like in my spiel, if I start talking about low dose naltrexone, I make sure that people are willing to try a few different doses and have some ability to do some dose experimentation on their own and have the ability to do that because they'll have to figure it out, of course, with your guidance, but often it is kind of a nuanced process. So overall, you want to start low. I have typically started with like the 1 milligram or 1.5 milligrams at bedtime. The LDN research group, they're actually recommending BID dosing for mental health. I had a couple patients we did that with, but you might want to try the 0.5 milligrams BID dosing, and then you can use either the 0.5 milligram dose capsule or like a 1 or a 1.5 milligram capsule just to keep things simple, and then have them increase that dose every 1 to 2 weeks is tolerated. Typical target dose is 4.5 milligrams, but there's a big asterisk with that. Some people, will find 0.5 milligrams to be their sweet spot. And some people, might be taking 4.5 milligrams twice a day, and that's more helpful than lower doses. So once you're at that target dose, then those refills can be ordered specifically at that dose. So they're not taking like 3 capsules at once. It can just be one pill. And consider BID or TID dosing for PTSD or depression. Really important, tell them to commit or ask them if they're willing to commit for 6 months for use of low-dose naltrexone. Some people might notice an improvement in their symptoms right away, and some it's much more subtle and it might take up to 6 months. And so if people come back to you and say, after 3 months, I haven't noticed anything, tell them just keep on that path and try it for 6 months. Higher doses might be helpful, like I said, for short-term acute TBI recovery, so the 50 milligram dosage. Dissociation, like I said, there's been the study showing that higher doses of naltrexone have benefit, but if you can use lower doses and have less side effects, just something to keep in mind. I'm including Dr. Bahari's low-dose naltrexone dosing protocol, which is a simple way, if you don't have a patient who's sensitive and let's say they have an autoimmune condition and depression, this would be a totally appropriate way to go. So like starting at 1.5 milligrams at bedtime between 9 to 10 p.m. If they're tolerating that, they can increase it to 3 milligrams at bedtime for 7 days. And then if they're tolerating that, they can increase it to the 4.5 milligrams at bedtime for maintenance. So let's say someone is sensitive to medications, they have MCAS symptoms, they have hypothyroidism. That's when you would consider starting, like I said, at the 0.5 milligram tablet or capsule dose, and increase by, 0.5 to 1 milligrams daily after 2 weeks, and then continue to increase as tolerated. If they don't tolerate that at all, consider changing to a liquid form. The dosing concentration my pharmacy has recommended to me for that is 1 milligram per 1 milliliter. So if they're taking 0.1 milligrams, which is a real small dose, that would be 0.1 milliliters. So it's a lot easier to get that precise of a low dose with the liquid. And so let's say they're really sensitive, they could start with the 0.1 milligrams daily, see if they tolerate it over a few days. If they do, then you could increase it by either 0.1 or like 0.2 milligrams, depending on how they're doing. I'll also say here too that the liquid form, I know Hui Pharmacy or Hui Apothecary that I work with a lot, they use almond oil suspension. Um, other like oils that could be used for the liquid form, I think, are like olive oil and avocado oil, but you can ask your compounding pharmacy that. What if someone wants to stop low dose naltrexone? What happens? So they don't need to be tapered off of it, but and this is sometimes how people know that it's working. So they'll stop it. I had one patient who was traveling and she forgot to bring the low dose naltrexone with her. And when she stopped it, that's when a lot of her symptoms came back, and she noticed how much benefit that the low dose naltrexone had been providing her. And so that was like motivation for her she wanted to keep taking it. So people can have a reemergence of previous symptoms. Interestingly, BMI is not seen to be associated with dose. Remember that a bigger dose is not always better, and that dosing is highly individual. Okay, real quick here. I think this is the last part. So case study, in brief, a 40-year-old male with childhood head injury and chronic fatigue syndrome diagnosis. He was diagnosed with mono at age 10. He had severe tonsillitis when he was 14, and then diagnosed with chronic fatigue syndrome young at age 15. He had a lot of profound fatigue, a lot of recurrent infections, just really sleepy, light sound sensitivity, headaches, depression. He did try some like lifestyle changes that improved symptoms somewhat. So there was like diet changes, moving to a dairy and gluten-free diet, pacing activities, and then getting a job that had a more flexible schedule, but still struggled with really low energy. So he started 1 milligram low dose naltrexone a day, gradually increased up to 4.5 milligrams, didn't notice any significant side effects. Outcomes, so he noticed improved sleep patterns and fewer colds. Depression scores also improved. So before he started, the HAD scale depression score was 13, which is in the depression range. And then after the low dose naltrexone, his score was 7, which was in the normal range. And also importantly, his functional capacity, it was like 60 to 70% before the low dose naltrexone, and then 80 to 90% after taking it. And so because he found so much benefit, he decided he wanted to continue to take it. So in summary, low-dose naltrexone, it's a promising adjunct for inflammation-driven psychiatric and medical conditions. Overall, it's safe and well tolerated, but requires patience both for us and our patients, and then individualized dosing. It seems best for conditions with immune dysfunction, chronic pain, and neuroinflammation. More research definitely is needed, but the clinical evidence is compelling so far. So that is all I have. Thank you for being here and for your attention. If you have any questions afterward, I'm by no means like an expert in low-dose naltrexone, but I will do my best to answer them or refer you to other resources. And then I think on the next slide, I do have some resource references listed here too. But does anyone have any? I'm going to just stop sharing my screen here a second so I can see in the chat. Oh, thanks, Anna. I appreciate that. Um, does anyone have any specific questions? I hope it didn't scare you away from low-dose naltrexone. You can either unmute or type in chat. But thank you all for the kind words.
Hi, thank you. I guess I'm just curious about your kind of algorithm for offering it when someone, comes to you with depression or psychiatric symptoms. I mean, for me, I'm kind of an addiction background and have a lot of patients with comorbid pain. And so if it's like the full circle pain and uh, like chronic fatigue syndrome and depression, I'll sometimes offer it because to me it's like okay, it's kind of tipping the scale where might as well
Yeah.
throw it and see what sticks. But if it's somebody just presenting with depression, I know you had this slide of some of those other variables, but I was just curious if you could say more about your kind of algorithm to decide when would you choose that over an antidepressant or some other kind of approach.
Yeah, I mean it depends on the person. I mean, if I have someone who's like, I don't want to take any antidepressants, um, then we can, that the low-dose naltrexone might be an option. I would say in my practice, and maybe other people have different practices, but I typically don't use it like as an alternative to antidepressants. I mean, it could be used if someone wants to like taper off. I would maybe consider adding it on board and seeing if we can decrease their antidepressant. Um, but yeah, I would say it's often I use it as an augmentation to other treatments. Often if I'm seeing someone, the low-dose naltrexone just might be one part of their treatment plan. But for a lot of people, it's like they'll tell me this has been a game changer for me, just in terms of their like mental health, but also like their physical health symptoms too. I know that's not very specific. I usually start, I would say for a lot of people, if they don't have sensitivity or the other issues that I brought up, I would start the 1.5 milligram dose and increase after 1 to 2 weeks and just have them take a 1.5 milligram capsule.
Thank you. Um, Appreciate it.
And there's a question, Shannon, have you had experience with treating depressive episode in someone with bipolar depression? I don't think I have. Um, I had someone with bipolar 2 disorder with depression is like the predominant aspect. And I believe she was taking low-dose naltrexone when I started working with her, but still had some significant depression symptoms. That's just like the one example. So for her, it wasn't particularly effective. Um, but I mean, I would imagine it might be. I don't know. I don't think it could trigger hypomania. Um, so that would be maybe a reason to try that more than some of the antidepressants. But I'm not sure. It's a good question. Anna, you wanna try it more often? Great. Thank you, Vicky. Thank you, Dulcia. So I think
Uh, oh,
looking at the time here, any other questions?
just I just had a patient that I had. Oh, well, I'm sorry if the laundry's going in the background, but I had a patient that I put him on it, and unfortunately, his mood got worse. And I saw you said 1%, and I think it's, I mean, who knows if it was related or not, but it was enough for me to say, okay, let's just get you off of it. I'm curious about your experience with mood changes for the worse with low dose naltrexone.
Yeah, and it's interesting because it could be, was it the low dose naltrexone? Was it my first thought is that was that a too high of a dose for that individual? And of course, if they're like having intolerable depression or SI, you don't want to necessarily like say, let's just go to a lower dose. You might just want to say, let's stop it. But I would just be curious if a lower dose would be tolerated. I haven't seen that happen for people. It's more of like in a reemergence of their physical symptoms going on, inflammatory symptoms, or the sleep issues. But I mean, it could be possible. And so just, yeah, making sure to either lower dose or just stop it, I think would be appropriate, like you did.
Appreciate it.
Right. Well, I almost made it to 7. We're a minute over, so thank you all. I will send out the recording. My hope is to do that tomorrow. So I'll send a follow-up email. But otherwise, email me, Dr. Berger, DRBURGER, at Driftless Integrative Psychiatry. And thank you all for being here and have a good rest of your night.
Thank you.
Thank you.